So, a blessed evening to all. I warmly welcome everyone to the sixth Cardio-Obstetric Masterclass and an important topic of discussion today, prosthetic valve in pregnancy. So, we would have come across this condition in our clinical practice commonly, but there are a lot of gray areas. And today, let us hear it from our experts. So, I now request the course director, Dr. G. Justin Paul, sir, to share a few words on the introduction about the Cardio-Obstetric Masterclass. Over to you, sir.
Thank you. You can stop sharing this one. Let the panelists all can be seen. Very good evening, all of you. We really warmly welcome you and thank you for joining this Cardio-Obstetric Masterclass. Now, why do we have this Cardio-Obstetric Masterclass? The very purpose is that we need to be aware of these areas, particularly pregnant women with complex heart diseases. This is one of the commonest causes of maternal mortality in developed nations. It is going to be one of the leading causes of maternal mortality in India. So we need to be trained cardiologists, obstetricians, obstetric anesthetists, and we need to join together as a team and work together to improve the care of these women. So what we are doing is based on Indian data, what are the diseases that are the larger contributors to maternal death? We are touching them one by one. We earlier dealt with pulmonary hypertension, we earlier dealt with heart failure. This time we are dealing a complex case of prosthetic valve thrombosis. In the largest study, a single center study in the world, prosthetic valve thrombosis, there is Madras Medical College Pregnancy and Heart Disease Study. Prosthetic valve thrombosis is the largest contributor to maternal death. So let us see how we need to save a patient with a prosthetic valve going through pregnancy, how we need to manage. Now, today's case will be presented by Dr. Annie Princy, who has been working in the field of cardio-obstetrics with me for the last 7 years. And she has extensive experience in handling these patients, managed a lot of cases of prosthetic valve thrombosis and prosthetic valve in pregnancy. This case, in fact, the chosen for today is a very complex case. The patient had multiple showers of emboli. The patient had a CVA. The patient had a prosthetic valve thrombosis and also developed a peripheral arterial embolism. However, for the sake of passing the message, that we are skipping that aspect of CVA and also the peripheral embolism. We'll be focusing primarily on prosthetic valve and prosthetic valve thrombosis. And let us see what are the things that we can learn from this particular case, which was masterly managed by a very large team. I request Dr. Annie to introduce the other panelists. Dr. Karthik, if it is fine, you can kindly switch on your video if you can.
I'm not able to. I'm actually trying. It says
okay. Medgami team, kindly help Dr. Karthikeyan. See if there is something you can do from your side.
Thank you, sir. So I'm happy to introduce a panelist for the session, Dr. G. Karthikeyan, Executive Director, Translational Health Science and Technology Institute, Faridabad. He has over 22 years of experience in rheumatic heart disease, mechanical valve thrombosis, anticoagulants, indigenous drug-eluting stents, genetics and epigenetics of homocysteine metabolism, and its relationship to CAD. He leads the first international registry of rheumatic heart disease and currently is working on the largest registry of RHD Invictus and is leading a large national multicentric randomized trial on digoxin and RHD. He has performed the first RCT in mechanical prosthetic valve thrombosis, and his subsequent works in PVT, comparing the thrombolytic therapy with surgery, led to a change in the guidelines recommendation for the treatment. He is a recipient of numerous international and national awards, holds eminent roles in various boards and committees. Around 200 publications in his royals with more than 85,000 citations. Dr. Manu Goyal, Additional Professor, Obstetrics and Gynaecology, All India Institute of Medical Science, Jodhpur. She has been the principal investigator of various WHO and ICMR-funded researches. She was honored with many awards during her academic as well as professional careers. She has published more than 18 research papers in national and international journals, including International Journal of Gynecology and Obstetrics and European Journal of Gynecology and Obstetrics, and e-books relevant to gynecological researches. Her research interests are high-risk pregnancy, minimally invasive surgery, and reproductive endocrinology. Dr. Manokanth, obstetric anesthesiologist, consultant, Fernandez Hospital, Hyderabad, with fellowship in obstetric anesthesia, MGH, Boston. He has special interest in medical disease complicating pregnancy and patient safety. He has many publications and author chapters in obstetrics and gynecology updates. Dr. Devagourau, Professor, Department of Cardiovascular and Thoracic Surgery, All India Institute of Medical Science, New Delhi. He has performed approximately 8,000 cardiac surgeries, including complex procedures like double root transfer, heart transplants, LVAD, and complex pediatric and adult valve repairs, stone repairs, and root transfer procedures. He has conducted live surgeries and workshops across India and internationally, invited speaker at numerous national and international conferences. He has published extensively in indexed national and international journals, about 135 publications, and reviewer of the various indexed journals. President-elect of Indian Association of Cardiothoracic Surgeons, and Scientific Committee Chairman, IACTS. So these are panelists today, and I am the presenter for today. So I'm Dr. Princy, Assistant Professor of Cardiology in Tamil Nadu Government Multi-Super Specialty Hospital. So now we are going to move into the presentation, and before we do that, I request all the audience to post your questions in the chat box, and wherever possible, we'll be looking forward to answering your queries during the panel discussion. We have a separate live Q&A session at the end of the presentation. So now we'll be moving into the presentation. Just give me a second. So as sir has, sorry. So is my screen visible?
Seen now.
Yes, sir. So this is a case of prosthetic valve thrombosis in pregnancy. As sir has suggested previously, the patient had to go through a lot of showers of emboli. And for our convenience and for today's presentation, we are going to take the prosthetic valve management part of it today. So coming to the cardio-obstetric team who had helped this patient. So I would like to thank my sincere thanks to the cardiology team of Tamil Nadu Government Medical Multi-Super Specialty Hospital and MMC, the vascular team of Super Specialty Hospital, the neuro team of Super Specialty Hospital and MMC, the obstetric team of Super Specialty Hospital and MMC, the anesthetic team of MMC, and the neonatology team of MMC. So this was a team that helped us to sail through this pregnancy. So we can see that this patient had a stormy antenatal period, but she sailed through a smooth peripartum period. And this is due to the efforts of the cardio-obstetrics team. And I sincerely thank Professor Dr. Rani, Chief of IOG, MMC Chennai. So moving to the history. So we have a 23-year-old primary gravida with a prosthetic heart valve. She presented to our ER with complaints of breathlessness, NIHA class 4 for 3 days. So these are some of the past history. The patient is a case of rheumatic heart disease, severe mitral stenosis, diagnosed at the age of 10 years. She had a valve repair done in 2010, and due to restenosis, a mitral valve replacement was done in 2012 with St. Jude's bileaflet valve. And post-operatively, she was on acetone 1 milligram, and then in follow-up, it was titrated to 2 milligram, and her post-op gradients were 6 and 16. So some of the pre-pregnancy details: the patient was in regular follow-up with cardiologist. Proper INR follow-up was done, and there's no previous history, pre-pregnancy history of any prosthetic valve-related complications. So the medication, she was on penicillin, aspirin, furosemide, and digoxin. So this is a pre-pregnancy acetone dosage and its INR monitoring, and we see that the patient had acquired good INR status pre-pregnancy. And coming to the antenatal history, she was married since 5 months. And after confirmation of pregnancy, the patient was switched over to heparin during the first trimester. So it was started at 7 weeks with unfractionated heparin injection, 5,000 international units, subcutaneous bleeding. And then she was referred to a tertiary care institute for further management. But the patient could not take the heparin dose regularly. So she presented to our ER with dyspnea. She was conscious and oriented. She was dyspneic tachypneic. She was, her pulse rate was 106, tachycardic, and she was in hypertension. And JVP was elevated. Her prosthetic valve sounds were muffled. There were scattered crepitations. And we did an echocardiographic evaluation, which revealed that the patient had a reduced mobility of the prosthetic valve leaflets. Her gradients were mean of 33 and peak of 45. Her DVA was 6.9. Her LV function was adequate. And her RV function, there was a mild RV dysfunction noted. Her pulmonary pressures were elevated. And there was no clot identified or no pericardial effusion. So this was the image. So here we have, coming to the diagnosis of primary gravida, dramatic heart disease, status was mitral valve replacement with prosthetic obstruction with severe pulmonary hypertension, secondary to prosthetic obstruction with RV dysfunction. So at this point of time, we discuss as a patient and triaging was done. And I have class 4, she belonged to the functional class, NWH of 4 at present. CAPRAC score was 8 and MPAC score was a very high risk score. So we'll move into the polls. Team, can we launch the first poll?
And dear audience, we are launching a poll for you. We would like you to answer, make your choices. I think Annie, okay, fine. Please give your answers. Request, thank you for voting. Request everyone to kindly vote, cast your opinions and inputs. We can discuss that. Most 60% of us have voted. And we can share results. So as you can see that majority of them have felt that low molecular heparin throughout pregnancy is the most effective regimen, followed by vitamin UFH switched over to VKA, and VKA throughout pregnancy, and unfractionated heparin throughout pregnancy. 61 of us have answered. Now, maybe before I go to the next poll, let us just share the inputs also through here. Now, when we talk about safety, we always, efficiency is that the patient should not have any complications. The regimen that we are using throughout pregnancy should be effective in keeping the valve safe, and it should be safest to the mother and the baby. So efficiency and safety. If you look at that, vitamin K antagonist throughout pregnancy is the safest regimen for the mother. It is the safest regimen for the mother. And low molecular heparin throughout pregnancy, if it is optimized by doing peak and trough levels of anti-10A level, it is fine. Otherwise, it is one of the most unsafe regimens during pregnancy in a prosthetic valve. Now, we are writing up the UORP data, the ROPAC3 registry, which have included 441 patients with the prosthetic heart valve and pregnancy. We have evaluated these 4 regimens, and unfortunately, we found that of all the regimens, the worst outcome came with the low molecular heparin regimen, and the safest outcome was with vitamin K antagonist. Now, if the vitamin K antagonist levels, that is the vitamin K antagonist, say acetone level requirement is less than or equal to 2, or the warfarin requirement was less than or equal to 5, you please continue vitamin K antagonist throughout pregnancy till 36 weeks. If it is more, still continuing them will be safer. The risk of warfarin embryopathy is about 2%. But however, the patient may be given an option of switching. So now, shall we go to the next poll? Launch the next poll. Which of the following patients you would like to have a switch? I request the audience to kindly vote. Thank you for voting for the previous question. We'll also get the inputs from the panelists. We are going to take a discussion break now. I think the first 2 questions, unfortunately, are the same. you please look at the screen to look at the second question. All patients with a mechanical heart valve. The second thing will be patients with a mechanical heart valve who have a higher requirement of vitamin K antagonists. I request the audience to kindly give your inputs by message. Yeah, so now what we find is both. So what is recommended is that patients with the higher requirement of vitamin K antagonists, say warfarin more than 5 or acetram more than 2, these patients can be recommended to have a heparin switch. Otherwise, we don't really need to do switch for these patients. Now, we'll get the opinion from the panelists. We'll come back. You can stop sharing. We can come back to the discussion. Maybe you can share the final diagnosis slide, Annie, so that audience can have a look at it. Now, Dr. Karthikeyan has an extensive experience in prosthetic valve thrombosis, and he is the largest randomized study in prosthetic valve thrombosis. Dr. Karthikeyan, let me ask you, what are the inputs you will give to help a clinician diagnose prosthetic valve thrombosis early? Number one. And number two will be, how will you manage these patients? What are the treatment modalities that you have?
Thanks, Justin. That's a long question. That's an essay question.
Yeah, I know you can give crisply.
So I don't know what you mean by early diagnosis of valve thrombosis, because we diagnose valve thrombosis only by symptoms. So if somebody has recent onset of symptoms of valve dysfunction, then we diagnose valve thrombosis. The problem is that if you do routine screening, like Dr. Devagourau also might remember, we used to do routine screening using fluoroscopy for patients, even when there are no symptoms. Then you tend to identify a number of patients who have possibly asymptomatic valve thrombosis, or maybe just some abnormalities of valve leaflet motion. And that leads to lots of treatment dilemmas, lots of complications, because patients have to be kept overnight or kept for a few days, given unfractionated heparin and things like that. So I would suggest that don't diagnose valve thrombosis unless patients come with symptoms, or there is a strong suspicion because patients have a very low INR for a long period of time. That would be the thing. And diagnosis of valve thrombosis is basically you need to have both abnormal valve leaflet motion on fluoroscopy and abnormal echocardiography, because fluoroscopy can also be, even we don't think that fluoroscopy can be abnormal in the absence of valve dysfunction, but sometimes in patients with atrial fibrillation or LV systolic dysfunction, you can have valve leaflet abnormalities, motion abnormalities, which are asymmetric and transient. So you need to have both echo abnormalities and fluoroscopic abnormalities for diagnosing. And for now, for treatment purposes, we are talking about symptomatic patients. For symptomatic patients, the regimen of choice would be based on the results of our recent RCT, would be the low dose, slow infusion TPA regimen, which is 25 mg over 6 hours and repeated if necessary for up to 150 milligrams. So that would be, I'll stop here because we can keep on talking about this.
Thank you, Dr. Karthikeyan. So what essentially he has said that is suspicion is different and diagnosis different. It's important to have a good index of suspicion when the patient has an unusual increase in symptom, worsening of symptoms, or the patient has, many times patients are trained to hear their own heart sounds. If they find that the heart sounds are not heard very well, if the doctor feels that there is a muffling of heart sounds, immediately we need to go for the diagnostic plan, and the diagnostic pattern, I think Dr. Karthikeyan has clearly spelled out. And he has also said the regimen used by there in the study. So the traditional regimen that we've been using is using streptokinase and tenecteplase. But over a period of time now, the slower dose and long regimens, the various regimens are being tried. Particularly very sick patients. In fact, people have even tried a rapid bolus lysis also. But none of these studies have been on pregnant women. Now, to the obstetrician, let me ask you a question. The patient is given a
Dr. Justin, just one more thing, because I was just talking in general. In pregnant women, the best regimen is probably the ultra low dose infusion, which was tested by the Turkish, which is 25 mg over 24 hours.
Voskan
That
group.
is, yes.
Okay, right. And Dr. Manu, let me ask you, what are the parameters, what are the things that you will be looking at observing in this patient? Now, in this early period, there, Dr. Annie is thrombolizing the patient. If you're the obstetrician there, what are the things that you will be looking for, and how frequently you would like to monitor this patient?
Yes, sir. Since the patient is in early or first trimester of her pregnancy, so and she has got valve thrombosis, and she has been thrombolized for the same. So we just need to, for fetal point of view, we need to first of all localize the cardiac activity, and if it is there on ultrasound, and because she's maybe 10 weeks or something. So we will just do an ultrasound for cardiac activity at this gestation. And further, we before and after the procedure is over, thrombolytic therapy has been given, and we can repeat the ultrasound after 1 week to see for the cardiac activity. And one more thing we would like to do at between 13 to 14 weeks of gestation, we would like to see any abnormal fetal abnormalities which can be picked up at this gestation. But most of the fetal cardiac abnormalities and other abnormalities would be picked up at a later ultrasound, that is the anomaly scan done between 18 to 20 weeks of gestation, and a fetal echo at 22 weeks. But before that, we have to thoroughly examine the patient also for other signs and symptoms, and any bleeding complications which can occur at this gestation because of the thrombolytic therapy and anticoagulants. So she might have to counsel her for in terms of abortion she can land up in. And if she lands up in abortion, so we have to take a consent for the same while we are going for that. So any in any form of threatened abortion or subchorionic hematoma or subchorionic hemorrhage or vaginal bleeding, so we have to explain that to the patient.
Thank you, Dr. Manu. I'll ask a question to a cardiac surgeon here. Dr. Devagourau, you've been doing a lot of cardiac surgeries for prosthetic valve thrombosis, but it is not always easy to mobilize the team and ship the patient for surgery. And even in your study, the mean time to diagnosis to the surgery was definitely longer than diagnosis to thrombolytic therapy. So by and large, we often end up doing thrombolytic therapy. So now the patient has a failed thrombolysis. And then what are the options now? The patient we have is referred to surgery. So what are the parameters that you'll be doing it? The second question is, if the patient has a prosthetic valve thrombosis towards the, say, 32 weeks or 36 weeks, when we think that the child is viable, and you have the team ready, what would you like to do? Would you like to thrombolize, or would you like the patient to be shifted to a cardiac surgical theater? How will you manage? Which one first? A delivery first, cesarean first, or how would you like to manage this patient?
Good evening. First, if there's a failed thrombosis, we'd like to depend on the gestational age. If it is towards the end term, then we'll prefer to ask the obstetrician whether we can have a delivery first, and then if something precipitates, immediately we can take that. Usually we do keep it in the our OR so that things can be expedited. The cesarean section or a vaginal delivery will be done in our theater. If something goes wrong, immediately we take, or even otherwise, once delivery is done, we go in for a surgery. That is a first option. Usually, if there is in the first or second trimester, usually when there is a failed thrombosis, usually we'll do a TE on table, because sometimes we have seen while assembling the pump, only when we put a TE probe, by the time we take, sometimes they open up. So that is one, we have to compulsory to have a TE intraoperatively. routinely we get a CT scan also done post thrombolysis to see if there is a bleeding in the brain, so that we can put when we have to go on bypass, we have to put the patient on full heparin. We have to achieve a ACT of 600, 480 and above. Routinely it's around 600. So we get in a pregnant patient, this may not be possible. If in case we have to put on bypass in earlier, we want to save the fetus when delivery is not possible, we'll try not to cool down the patient to avoid a fetal loss, and probably we'll try to have a pulsatile flow. The perfusions can allow a pulsatile flow to mimic the placenta so that there is no fetal loss. Despite all these efforts, the fetal loss will be very high if you are going to intervene in the first or second trimester.
Thank you, Dr. Devagourau. We appreciate your inputs. Now, one more question to you is that when a patient becomes pregnant, a patient operated by you becomes pregnant, by and large, they first come to you. When they come to you, they are probably around 6 weeks or so pregnant or 5 weeks pregnant. So, what will be, what should be the ideal advice by a CT surgeon?
Ideally, the classical teaching is shift over to low molecular weight heparin. But if as you said, if the acetone doses are below 2 or 2 and below, or warfarin doses are 5 and below, despite all the weight, Indian weight also, still we go at 5 and 2 only. If they are below 5, I think we should leave it like that, because there is no difference between converting to low molecular weight heparin, because low molecular weight heparin, though it is safer for the fetus, it may not be as safe for the mother. So the chances of thrombosis is much higher, much higher compared to warfarin alone. In case if it is above, ideally you should switch over to low molecular weight heparin. If the warfarin dose is above 5, probably even the first 6 weeks is already, whatever damage had to be done is already done. Despite that, we prefer to switch over to low molecular weight heparin, but at least for the first 12 weeks. Then switch over to warfarin again.
Yeah, thank you, Dr. Devagourau. This is one thing I think we specifically asked this question to us. Now that we know standalone low molecular heparin is not something that we should be using unless we have an anti-TNA monitoring facility. Medgami team, can you just create a poll? We use LMWH with anti-TNA. Yes, no, that is all. The question is, we use low molecular heparin with anti-TNA levels. The options are yes and no. I would like to know how many of our people use an anti-TNA level with low molecular heparin. So it is very important that the surgical team is also equipped about the latest knowledge. If you look at the surgical team, generally will be looking at what is the latest in surgery, what is the latest development in surgery, latest development in the valve. But we may not really focus on what is the best anticoagulant regimen for a pregnant woman with a prosthetic heart valve. So it's very important that whether the patient comes first to a surgeon or to a cardiologist or to an anesthetist or to a relative or a general physician, these patients are referred to a center immediately with the cardio-obstetric expertise who know what they are handling. So, Dr. Karthik, I would like to ask you, because sometimes we find women with the prosthetic heart valve, many times, even primaries, I've seen patients are advised MTP. So, is this a scare? Is it contraindicated in pregnancy in patients with mechanical heart valve? How do you clear this information?
Sorry, just come again about the question about getting pregnant with a prosthetic valve, or
is it contraindicated? Pregnancy is contraindicated in patient with prosthetic heart valve?
No, definitely not. Definitely not. And there is it just if a pregnancy is planned, it probably gives us the opportunity to discuss all the options of anticoagulation with the patient, because then the crucial first, it's actually not the first 6 weeks, it's actually 6 to 12 weeks. That is what warfarin affects. It's not the first 6 weeks. So we do have the opportunity of discussing this and planning this very well with the patient and the other treating team. But in my experience, irrespective of the dose of warfarin, it is better to continue warfarin. It's impossible for us to treat maintain adequate anticoagulation with either unfractionated heparin and definitely not with low molecular weight heparin, because we just don't have anti-10A. We can't even manage INR. We can't even manage APTT well. It's just not possible. It is not possible. So I would just not recommend anybody to switch to UFH. We've had this on some occasions and we've really burnt our fingers. It's not possible.
So, dear audience, I would like you to know that you are hearing it from somebody who has been managing prosthetic heart valve for such a long time, has been studying in multiple publications on prosthetic heart valve. Better to continue vitamin K antagonist throughout pregnancy and screen for, fetal abnormalities.
And fetal abnormalities, when we say that, actually there is only one study which looked at this. Where are these data from for 5 mg versus less than 5 mg, more than 5 mg? In fact, there are no data for acetrom at all. It is just that we are extrapolating from the dose of warfarin. And this is from a German series. And the risk of fetal abnormalities. So we are not talking about warfarin embryopathy. That is a complete full-fledged syndrome. That is extremely rare. We're talking about minor abnormalities which can happen. That is about 1%. So, and it doesn't make sense. No? So supposing somebody is on 15 mg of warfarin, you think about it very seriously. But if somebody is on 6 mg of warfarin, you don't want to just take that as a cutoff and just switch them over. So the risk is quite small. And in my experience, if you talk to patients, tell them these are the issues, and the numbers are much greater on the other side. If you see, the risk of warfarin embryopathy is 1%, but the risk of valve thrombosis is substantially higher, and the risk of bleeding is substantially higher with any other regimen. So if you give these options, patients understand, then they will always choose to continue warfarin. It's so much more simpler. Only thing is, you make sure that you intensify your INR management regimen. So initially, if you were doing it every 4 weeks, you probably do it little more. Pregnancy is anyway a thrombophilic state, so you need to really be very careful with INR monitoring. So that's what I would suggest.
In addition,
thank you very much, Dr. Karthikeyan. If there is one message I want the audience to carry home today, this is the message. Continuing vitamin K antagonist throughout pregnancy is the safest. Do not switch over to low molecular heparin unless you have facility to monitor anti-10A levels and you are able to do peak and trough levels. And about the warfarin embryopathy, he said it's extremely rare. In our data that we have sent it for a European Heart Journal, I don't know whether it will be published. It is under review. 441 patients with prosthetic heart valve in the ROPAC 3 registry. We didn't have a single case of warfarin embryopathy. Dr. Devagourau, you are about to say something. Please go ahead. You are muted.
So
Meanwhile, after Dr. Devagourau speaks, you can launch the poll.
Yeah. By the time the patient reaches you, it's already late. If something had to happen, they would have happened already. So that is why we feel there's no need to switch. They usually come after 6 weeks or 8 weeks. By the time whatever has to happen must have happened.
Yeah. Medgami team, can you launch it? So we use low molecular heparin. So those of you who don't use low molecular heparin, just click the third one. Those of you who use it and you're using it, the anti-10A monitoring, click the first option. So those who do low molecular heparin without anti-10A, click the second option. So we have 13 of our members. We really would like to know from the 14 of our people who have answered low molecular heparin, the anti-10A monitoring. Those 14, you are really experts because you have the facility to do anti-10A monitoring. Please send a message in the protocol, in the chat box. What do you do? What kind of practice that you have? When do you monitor? How often you monitor? Do you monitor the peak levels? Or do you monitor the trough levels? It'll be nice if we can get all of you to speak, but then in the interest of time, we are not able to call you to speak. But these 14, 15 of you, kindly share what you do, your practice patterns in the chat box. So most of us, I think 16 do not use low molecular heparin, and about 36 we are using low molecular heparin without anti-10A monitoring. It is presently not recommended, so let us not do that. And do we have the time for discussion, or should we go for the next? I think
Can take another 5 minutes.
okay, patient. Dr. Manu, if the patient visits you for the first time, what will be your advice? And yeah, I think most of us, we have touched about anticoagulation regimen. What will be your advice?
Yes, sir. So if the patient comes to me with the prosthetic heart valve, and so I would like to see the
1 minute, 1 minute, Dr. Manu. Medgami team, apparently the chat box is disabled. Is it possible for you to enable the chat box? Dr. Ajay Bahal, he's a senior cardiologist in PGH Chandigarh, has messaged that the chat box is disabled. That is in the Q&A he has mentioned. So can you kindly, enable the chat box?
Done for all, sir.
Done for all. Ajay Saab, please kindly, it is okay for you now. You can please share your inputs. Dr. Manu, sorry for interrupting. Please go ahead.
Yeah, okay, sir. So, if the patient comes to me, sir, for the first time, then I would like to see her. First of all, I would like to evaluate her clinically, and history would be taken regarding her anticoagulation, whatever she is taking, and then what is her condition like clinically, what is she NYHA class? I have to classify her accordingly, and I will do her counseling regarding the all the risk involved with the anticoagulants, and whether she wants to continue the pregnancy, and if she, or because some patients have completed their family and they land up in unwanted pregnancy, so I have to take her consent for continuation of pregnancy with all the risks involved, which could be in terms of maternal and fetal, both the risks. I have to explain to the patient risk of thrombosis, risk of going into cardiac failure, and risk of requirement of admission. And I would definitely like her to explain the major risk factors or precipitating factors for cardiac failure, like infection or fever or anemia. I would like to correct, and basic investigations which we do for antenatal women. We have to. Will have to advise to her. And first, more then from fetal point of view, I have already told you that we have to do a detailed anomaly scan between 18 to 22 weeks, and between 22 to 24 weeks, I have to see whether the heart lesion is congenital or it is acquired in terms of rheumatic heart disease. So if she has a congenital heart disease, then definitely her fetus is also at increased risk of cardiac problems. So I have to do a fetal echo between 22 to 24 weeks. And otherwise, these vitamin K antagonist can be continued throughout the pregnancy. And I have to also monitor her INR weekly during pregnancy. So yeah, once it is stable, we have to continue with that, and we will monitor it weekly. And also that I have to tell her regarding that she should be attached to the hospital, and she should reach the hospital, any hospital facility, within 15 to 20 minutes. So for any emergency condition, if it is if it arises. So that would be my counseling points for her. And later, we have to formulate a plan for delivery also between 34 to 36 weeks of gestation. So she should be counseled regarding that. And we will discuss about it later if the pregnancy continues fine. So that is our way of monitoring her and counseling.
So thank you, Dr. Manu. So dear audience, thank you for listening patiently. Now we move to the next one. Let's see listen from Dr. Annie what she has done.
So the patient was admitted in a ER, echocardiogram was done, which I have displayed now. So her admission INR was 1.1. So the patient was immediately lysed. Now, sir has told the RTPA regimen of 25 mg over 24 hours, but we did it with streptokinase. So we gave a loading dose of 2.5 lakhs international units over 1 hour, and a maintenance dose of streptokinase infusion 1 lakh units per hour over 12 hours. So this was followed by heparin infusion 1000 units per hour. So patient became symptomatically better. So her breathlessness reduced. She was continued on heparin infusion we restarted 3 mg of acetone. Her heparin infusion was continued with APTT and PTNR monitoring for acetone. So her NIHA class improved, and we got an obstetrician opinion. So there was no bleeding PV. So a bedside ultrasound was done. Single live intrauterine gestation with a gestation age of 9 weeks and 4 days. CRL was 2.27 centimeters and cardiac activity was seen. So we faced a very big problem in our INR monitoring. She had a very labile INR. And so we thought we'll switch over acetone to warfarin. So we started on her on 3 milligrams warfarin. So ultimately, her INR stabilized to 2.5. Heparin infusion was stopped, and patient was discharged on day 24. So this was a pre-discharge echo. So we found the normal mobility of the valve leaflets. Her gradients reduced to 6 and 8. Her DVI reduced. There was no pulmonary hypertension, and patient was discharged. So we'll break here.
So now this patient has been appropriately managed with thrombolytic therapy, and thankfully the patient has responded well. So Dr. Karthikeyan, may I hear from you, what will be your recommendation on how frequently we should do the INR follow-up now that the patient had an episode of PVT and it was lysed? How often you would like to do that? And what if you are even we are not using anti-10A levels, so maybe you can just tell us about INR monitoring and TTR. What will be your preferred way of managing?
So Dr. Justin, can I make a comment about the streptokinase? Because
please.
So I know that you have also published some data on streptokinase, the case series, but whatever we have seen so far, the complication rates are pretty high with streptokinase and the success rates are pretty low. So the only RCT, we did an RCT way back in 2009 in which we compared two regimens. In fact, we thought that streptokinase, the way that we used to give slow dose infusion, low dose infusion, that is what you have given. We thought that we could improve on that by accelerating the regimen like we give for STEMI. So we found that neither of them really worked. I mean, if you really go by the strictest definition of successful valve restoration of valve function, which means successful valve function restoration by echo and fluoroscopy in the absence of complications, it is not more than 65%. And the risk of complications are pretty high, especially in patients who are NYHA class 3 or class 4. So I know the costs are an important consideration when you're giving TPA, but remember that whatever we have seen subsequently, and even in our current trial, the median dose of TPA that is required is only 75 mg. So you have 25 mg doses. So, and the success rate, even in although it's not as high as what the Turkish group claims, it is more like 80%. So that is probably the best regimen now and the safest regimen. The complication rates are definitely lower than streptokinase. So I would tend to give that rather than streptokinase. So that is number one. Sorry, I digress from your question.
Perfectly fine. Perfectly fine. I think Dr. Karthikeyan's point is very well taken. As of now, we don't. The thing is, money is a big issue, and whatever is available in a situation, you need to use. But at this point of time, I'll also say that we are sitting on a large data. We have collected the data. We don't have time to analyze and publish. We have data on 450 patients with the prosthetic valve thrombosis who are thrombolized. The data is sitting with us. We're still collecting prospectively the data. And as you rightly said, that the success is not just sufficient that the valves are improving. I know that you are doing a study. I think one of your students is also doing a study on residual flow abnormalities using a 3-dimensional MRI. These things are definitely known to exist, and these patients are more prone for recurrent thrombosis. So, but as of now, if you don't have it in active place, do not worry. Please give streptokinase. It's life-saving. In the meanwhile,
sure, I agree with that. You have to go with what you have. But I'm just saying that if you have the option of giving TPA, go ahead and give TPA, the low dose regimen. So coming to your question of INR monitoring subsequently. So we run actually a prosthetic valve clinic which only looks at patients who are post-valve thrombosis. So the regimen that so the best thing I would suggest is use an algorithm, use a nomogram to change INR doses, and also consider, especially patients who've had multiple valve thrombosis, consider a higher INR range than the one that is recommended in the guidelines. So you target something higher. Our patients are younger. This is not evidence-based. Our patients are younger, so I feel that the risk of bleeding is much lower in these people. So it may be wise, especially in patients who've had multiple episodes of thrombosis, to target a higher INR range. And one more thing that you can do is ask them to monitor INR a little more frequently than what they normally do. Normally, our patients don't do INR monitoring. They do it every 6 months or so. So it's tragic. But every month is minimum. But if you have a clinic or if you have a special clinic for such patients, you have to teach them how to change their doses, even if they are not able to come. So that is one of the ways you can do that, is just tell them rules of thumb, give them a nomogram. We use a nomogram in the prosthetic valve clinic. So that's how we would do it.
Thanks, Dr. Karthikeyan. And about the anti-10A levels, a lot of questions are being asked. It's very important that, even when you're doing anti-10A levels, the lowest dose is above the, minimum recommended level, and the highest dose is not exceeding the safe level. So that is why I think many sites in UK, in fact, I was talking with Dr. Mark Johnson, who they routinely do peak and trough levels periodically. Every 2 weeks, these women come and they give the samples. Now, Doctor, I requested Dr. Pooja Sikka to join the panel. She is an obstetrician with a special interest in cardio-obstetrics from PGI Chandigarh. Dr. Pooja, can you just let us know what is the because I know they do anti-10A levels. What is the anti-10A protocol that you follow? Dr. Pooja, you can speak now. You are unmuted.
I will unmute.
Yeah, please.
So am I audible?
Very well,
Yes,
very well,
ma'am.
please.
So we follow the protocol of starting the patient on LMWS during the period of embryogenesis from UPT positive to at least 12 weeks. And we generally start the patient on 0.4 to 0.6 units subcutaneously BD. We try to monitor the anti-10A level daily because we have a free through JSSK, Janni Shishu Suraksha Karyakram. And then once it is achieved, not the trough and the crest levels, we are not doing in the laboratories as of now. Between 0.8 to 1.2, we do it weekly. Weekly, it has to be done. And if the patient is not able to achieve this value between 0.281 to 1.2, we admit the patient and then we put the patient on unfractionated heparin subcutaneously TDS, basically 500 international units per kg. And then we start the patient on warfarin or acetrom till 36 to 37 weeks. 37 weeks again on Clexin or LMWH, and pre-delivery just 1 day before we start the patient on unfractionated. That is the protocol we follow, sir.
Thank you, Dr.
And we have seen many cases of prosthetic valve thrombosis. Like this patient, she was on 5,000 international units BD. This is not even a prophylactic dose.
It's very inadequate dose. This is what is practiced. Why we highlighted to share that was this was being practiced in the society, and we see the patients who are ending up in prosthetic valve thrombosis. So we really need good awareness. Now, in fact, a lot of our audience are very interested in knowing about the anti-10A levels and monitoring. That is why we requested Dr. Pooja to join us. Now, we also have another eminent panelist. We requested her to be a panelist, Dr. Geeta Kandavello from National Institute at Malaysia. Dr. Geeta, can you let us know about your anti-10A monitoring and your experience? Thanks for joining as a panelist, agreeing in the last moment. Dr. Geeta? Dr. Geeta, are you there? I think Dr. Geeta has given a detailed review. about the protocol. Maybe we'll just move back to her when she's free. I think she has.
Dr. Justin, can I ask Dr. Pooja a question? She
Please,
mentioned.
please.
She mentioned. Dr. Pooja, you mentioned subcutaneous heparin.
Yes, that is the problem with us. We do not give an infusion of heparin. Still, we are giving subcutaneously QID or TDS,
No,
unfractionated heparin.
I
And that
think
is
you
the
should not.
biggest mistake we are doing, but we are doing.
Dr. Pooja,
Because-
what we do is that, we admit them between, at least, I admit them between 6 to 12 weeks. It is a very tough and tedious job. I give intravenous infusion titrated by anti-10A levels. Dr. Manokanth, you are also from a big,
for
obstetric
UF,
center.
Dr. Justin, for UFH, you do anti-10A levels.
I'm
No.
sorry.
No, sir, APTT, sir.
We
APTT.
don't have
levels.
anti-10A.
Okay, you said
I slip of the tongue, I'm
The
sorry.
problem, Dr.
We don't have
Karthikeyan, is
APTT.
that we have to immobilize the patients. The patient is admitted, and for continuous infusion, it is very painful for the patient and for us
Yeah.
also.
So that's why
Hello.
I don't know. You joined later. That's why I suggested that we should not give
Yes,
unfractionated heparin.
we are
Continue
not
patients
going-
on warfarin.
Yes.
Sorry, Dr.
I fully agree.
Hello.
Dr. Manokanth is our obstetric anaesthetist. He's working in Fernandez Hospital, a very high-risk obstetric center. They manage a lot of prosthetic and pregnancy. Dr. Manokanth, you can give your inputs.
The reality is still in many places, unfractionated heparin is being used subcutaneously. And APTT monitoring also is not being done religiously. Most of the times, they may end up using 7,500 units thrice a day or 10,000 units twice a day. So these are the common dosages people use. Here in our hospital, we usually use low molecular weight heparin, 1 milligram per kg twice daily. But again, we don't do factor 10A monitoring. But the reality is, in many places, unfractionated heparin is used subcutaneously for therapeutic dosing.
Yeah, the sad reality is that we don't have objective data in the dose, how to use unfractionated heparin. We don't have very strong objective data. And low molecular weight heparin, again, though many people are using in developed nations, unfortunately, the publications are not that very big enough to say that very strong recommendations can be there. And even in this ROPAC 3, we found that low molecular heparin has the worst outcome. And also, the outcome did not vary between centers which monitored anti-10A and those who did not monitor anti-10A. There is a surprising finding. Once it is published, we'll know about that more.
So, just to add on to that, there is a pathophysiologic basis for not giving low molecular weight heparin, because they are more, they act more on factor 10A, 10 rather than the other. So contact activation is not inhibited by. That's why we don't use DOACs in patients with mechanical heart valves, because contact activation remains active in these patients, and this is one of the commonest causes of thrombosis. So it may not be a good idea to use low molecular weight heparin at all, because the ratio of action on factor 10 versus ratio on action to the action on 2 thrombin is much greater in low molecular weight heparin. They were very good for coronary syndromes where you had this balance which was much better, but not for valve thrombosis or valves, mechanical.
So Geeta ma'am is live.
Hello, good evening. Can you hear me now?
Yes, ma'am. Very well.
Yes. Good evening, everyone, and thank you for giving me the opportunity to share our input. Thank you, Dr. Justin. I just want to share our experience with anticoagulation. One of the most important message I think that was highlighted here is that the option of using warfarin throughout the pregnancy. If you have a lot of experience in warfarin, you can monitor the warfarin well, and you are safe in that sense in terms of ensuring that the mother's anticoagulation is optimal and to prevent valve thrombosis. However, in our experience, there is the issue about balancing with fetal outcomes. if we are going to change to any other mode of anticoagulation, whether it is unfractionated heparin or low molecular weight heparin, as clearly mentioned by the panelists, you have to have very optimal monitoring of the patient, either with APTT for unfractionated heparin or anti-factor 10A, both trough and peak levels for low molecular weight heparin. We were initially using the regime of unfractionated heparin, warfarin, and then unfractionated heparin again, like most people. But the problem with unfractionated heparin, as you would have experienced, is that it's very difficult to we use continuous monitoring, and we had at some point also use intermittent injections. But to actually achieve the APTT and to sustain that was something that we had problems with. And also the patient's compliance to the treatment, especially if it's inpatient. So that's why we opted to try a low molecular weight heparin and with anti-factor 10A monitoring. So when we started that, I think the most important thing is that in the initial phase, you would need to actually monitor the anti-factor 10A, both trough and peak, closely. So we start with 1 milligram per kg per dose of low molecular weight heparin. And after 72 hours, we check the anti-factor 10A. And if stable, then we can follow up these patients weekly. But generally, the patient needs more than 1 milligram per kg per dose. So we will have to increase it usually by 10 units and sometimes even a bit more, and then revisit again the anti-factor 10A after another 72 hours. So every 3 days we check until the patient is stable. Every time we increase the dose, it's like by 10 units of low molecular weight heparin. And then once stable, I think as mentioned earlier, it's either weekly or 2 weekly, depending on the patient's progression of her gestation. Few things that we have learned is that there is that risk of sometimes retroplacental bleed that sometimes you see. So at that point, you have to be a bit careful to monitor the baby and a bit closer. Another thing that we have learned is that sometimes you find your trough levels and your peak levels don't tally. You may have very good peak levels, but you may have low trough levels. So in that situation, you may have to adjust the dose. So you might end up with a patient whose night dose may be higher, the evening dose of low molecular weight heparin may be higher than the morning dose that you're giving, so that you can have good trough and peak levels. So sometimes you find a patient who'll be on 80 milligrams in the morning and maybe 100 milligrams of low molecular weight heparin at night. So this sometimes there is some variation to achieve the dose. And we found that to get good control, you need to at least have about 2.5, sometimes you have to go up to 2.5 milligrams per kg per day of low molecular weight heparin to get the good trough and peak levels. And usually we keep them on the low molecular weight heparin and stop the low molecular weight heparin about 24 hours before the patient is subjected for delivery. That's our experience.
Thank you, Dr. Geeta. And I think in the interest of time, we need to move forward, get back to the case. And just one snippet from our ROPAC 3 registry is that there was one factor that was associated with adverse outcome is more frequent anticoagulant level monitoring. That is surprisingly associated with the adverse outcome. And we believe that that probably led to more frequent changes of dosages, and probably this could have led to that. Anyway, step aside, we'll get back to the case. Dr. Annie, you can go ahead with the antenatal follow-up.
Yes, sir. So coming to the antenatal follow-up of the patient, during the second and third trimester, patient continued to be in functional class 1 and her vitals were stable, the prosthetic click was audible, and she was in sinus rhythm. These were her gradients. And so one thing I just want to highlight in this case that we had a very tough time in monitoring the INR. So it was not a stable plateau, it was like up and down. And so we had to monitor her frequently. And this was an anomaly scan that Madam was also talking about. So 20 weeks and 5 days. She had an anomaly scan done and it was within normal limits. And we also did an interval scan frequently as per the suggestion of the OGCN. So, and before we move into that, we'll stop a break. I'll just discuss what delivery plan we had. So we had a plan of admitting the patient at 36 weeks. We had a plan of switching over with heparin from VKA, labor induction, vaginal delivery, heparin infusion 6 hours after delivery, and to restart VKAs by 24 hours. This was what we thought, but I'll just tell you what happened. So we'll
can you
stop a
launch
break
the
here.
poll 3, the delivery plan poll, Medcami team, can you launch it? Audience, thank you for voting for the previous polls. Please vote for this as well. What will be your plan of delivery? Dr. Annie's plan was vaginal delivery, and the team Cardio-Obstetric team's plan. I request everyone to give your vote. We are learning from each other. This is an area where there are areas where data is not complete. So we do things on experience base and based on circumstantial evidences and case series, not randomized control studies. So about 758 have answered. Yeah, half of the participants have answered. Sincere thanks. Another 10 seconds, we can wait. So majority of voting for vaginal delivery. It is agreed that vaginal delivery is a recommended mode of delivery. However, in the ESC guidelines 2018, they say that in patients are more prone for prosthetic valve thrombosis, cesarean may be a better option. Anyway, we'll go to the next poll and then break for the discussion. Go to the next poll, launch the next poll, please. So what will be the plan of anticoagulation? So neuraxial anesthesia is contraindicated. Which are the following conditions? Now, if you would like to do a neuraxial anesthesia, last dose of low molecular heparin was given more than 24 hours back. Last dose of subcutaneous unfractionated heparin given 6 hours back. An intravenous unfractionated heparin stopped 6 hours back. An anti-10A level less than 0.01. Which of these is contraindicated for pregnancy? And
So which
maybe
you will not do.
For neuraxial.
Yeah.
Yeah.
We should not be using neuraxial anesthesia in which of these
Which
4
of them?
conditions? 3 you can use, 1 you should not use. And once the poll is done, I'll request Dr. Manokanth to answer this poll and explain. Manokanth is our obstetric anaesthetist from Fernandez Hospital, Hyderabad. Dr. Manokanth, the answer is yes. You can discuss the answers.
Yeah, so most of them has opted that intravenous unfractionated heparin stopped 6 hours back. You should not use neuraxial anesthesia. However, the correct answer is subcutaneous unfractionated heparin stopped 6 hours back. So actually, the idea of asking this question was, subcutaneous unfractionated heparin is not recommended for therapeutic anticoagulation. However, like I've mentioned, it is still widely used. So I wanted to, and ACOG and Society of Obstetric Anesthesia and Perinatology actually says subcutaneous unfractionated heparin. So they do consider using it for therapeutic anticoagulation. And they say a dose of more than 20,000 international units of unfractionated heparin per day can be considered as therapeutic anticoagulation. So when you're using unfractionated heparin for therapeutic anticoagulation, you have to have at least 24 hours gap, especially when it is using subcutaneous dosing. It is different from IV unfractionated heparin. IV, you can stop it, and after 6 hours, measure APTT levels. If they have normalized, you can use neuraxial anesthesia. So at the same time, I want to mention about low molecular weight heparin. There it is very clear. 24 hours, if it is therapeutic dosing, that is beat twice daily dosing, you have to wait 24 hours before you give neuraxial anesthesia. Again, restart it after 24 hours. So this is about the gap that you need to do with the IV unfractionated heparin. If it is subcutaneous unfractionated heparin more than 20,000 international units per day, then 24 hours you have to stop from the last dosage. And similarly, LMWH, you have to stop 24 hours from last dosage.
So thank you, Dr. Manokanth. This is the reason why then we may have to give a longer gaps. So this is one reason why when high-risk patients are more prone for prosthetic valve thrombosis, ESC recommends that cesarean section can be considered where a shorter period of anticoagulation stopping is possible. Dr. Manokanth will continue. What will be your choice for label analgesia in this patient? She goes in for vaginal delivery.
So for practical, if we are able to get that gap, so normally what happens, these patients usually are on vitamin K analogs, and then which is stopped at around 36 weeks, and then shifted most of the times either to low molecular weight heparin or unfractionated heparin. I suspect very few will be actually admitting the patient and giving IV unfractionated heparin for 2 weeks. So most of the times it is subcutaneous unfractionated heparin or subcutaneous low molecular weight heparin. So you can continue low. So what happens is you continue low molecular weight heparin, admit stop VKS at 36 weeks, continue low molecular weight heparin with the factor 10A monitoring, and then switch over from low molecular weight heparin to unfractionated heparin, ideally infusion at 36 hours before planned induction. So ideally, you have to infuse unfractionated heparin from 36 hours before planned induction, low molecular weight heparin, start unfractionated heparin IV infusion, continue it till the patient is in early labor, and then stop unfractionated heparin IV infusion. And after that, once the patient sets into established labor and there is a gap of 6 hours and APTT has been normalized, check APTT before you go for neuraxial anesthesia. If APTT is normalized, then you can safely place an epidural catheter and start low-dose local anesthetic with fentanyl 2 mics per cc and do a labor analgesia till the patient delivers. So as long as the patient is in labor, you would have stopped unfractionated heparin, and post-delivery, wait for at least around 6 to 8 hours and restart IV unfractionated heparin. Before you restart IV unfractionated heparin, see that you remove the catheter at least 1 hour before you restart IV unfractionated heparin. So this is the usual protocol. Let's say the patient is in labor, APTT has not yet been normalized, then you have other options like remifentanil PCA, patient controlled analgesia, or fentanyl PCA. Remifentanil PCA, you need one-on-one monitoring because the main problem here is respiratory arrest and bradycardia. So you need to closely monitor. The usual dosage is you start at 40 mics bolus, and there is a lockout of 2 minutes. So PCA is patient controlled analgesia. Patient has a button. When she presses, 40 mics of remifentanil goes in, and then for the next 2 minutes, there is a lockout. But the patient has to be monitored closely. Remifentanil is an ultra-short-acting opioid. It is metabolized by pseudocholinesterase. So the effect just vanishes after 2 to 3 minutes. That is one thing. Or you can also use a fentanyl PCA. Fentanyl PCA, usual doses are about 20-25 mics. So patient presses, 25 mics of fentanyl goes in, and the lockout here is about 10 to 15 minutes. This you can use till APTT has been normalized, and then decide if it is working well, you continue that, or you put an epidural.
Thank you, Dr. Manokanth. Dr. Karthikeyan, let me ask you, when do you feel this patient should be admitted in the third trimester? And what do you think is the role of the cardiologist? What can he play in this patient in the peripartum period? What would be the advice out of the roles a cardiologist can play? This can be helpful to all the cardiology residents, and the young cardiologists will be called to give their inputs in the labor ward.
So this patient, as I can see, this patient doesn't have any hemodynamic abnormalities because of the prosthetic valve. So she's as good as a normal patient, normal pregnancy. The only issue here is management of anticoagulation, and that has been explained by Dr. Manokanth. There should be no hesitation in suggesting that this patient should normally undergo vaginal delivery. In fact, the more you complicate this, the more likely that you're going to get into complications of abnormal anticoagulation and valve thrombosis, things. So I I would just highlight the fact that if the valve function is normal, LV function is normal, there is no PAH, this patient is as good as a normal pregnancy. They should have vaginal delivery and just manage the anticoagulation.
Thanks, Dr. Karthik. Dr. Manu, I have a question for you. How often is this postpartum hemorrhage in these patients and anticoagulation? What will be the contraceptive advice you give for this patient? This will be the last discussion break. Then we'll go back to see what happened to the patient. So 2 questions I've asked you. What about bleeding, postpartum hemorrhage in patients on anticoagulation? And what will be the contraceptive advice for this patient?
Okay, so regarding sir postpartum hemorrhage, it is common when we start the anticoagulants very early in the postpartum period. So what we think that we should be starting unfractionated heparin at least after 8 to 12 hours after the delivery in therapeutic dose. And if we have to start low molecular weight heparin, like many people are doing in practice, so it has to be started after 12 to 24 hours. So once the initial period of primary postpartum hemorrhage is over, we should be vigilant, and then we can start after 8 to 12 hours of delivery that unfractionated heparin. And the initial dose can be prophylactic dose, which we're starting, and then within next 12 hours, we can escalate the dose of anticoagulation just to prevent that primary postpartum hemorrhage. And sometimes we have seen in cesarean section that these patients end up in reactionary or secondary hemorrhage, which might be, patient has to be taken up for re-laparotomy, and sometimes after vaginal delivery, they land up in secondary postpartum hemorrhage. So we have to be very judicious, and we have to, look for APDT also. So initial anticoagulation should be in what we practice as prophylactic anticoagulation dose for initial 12 to 24 hours, and within next 12 hours we escalate the dose. And after 72 hours, we start 72 to 96 hours, we start vitamin K antagonist also. And for contraception point of view, these patients should be counseled before we are making a plan of delivery. At that time only, they should be counseled for maybe long-acting reversible contraceptive in terms of intrauterine contraceptive devices. So which is very safe, and nowadays it is also MEC criteria too in heart disease patients. So, and we can give definitely a better cover of antibiotics just to prevent the infection. That is the only risk with contraceptive devices, intrauterine contraceptive devices. So that should be definitely advised to them.
Sir, you are muted.
Sir, you are muted.
Thank you.
Hello.
So thank you, Dr. Manu. We have another 16 minutes left. So what we will do is we'll allow Annie to present and let us know what happened to the patient. And then there are a lot of questions in the Q&A sessions. I request the panelists to be kind enough, whenever possible, to type an answer then and there itself, so that all the audience can see. And then what is left behind, we can answer live. I also thought, I had the take-home thoughts later, but what I will do is, after Annie's presentation, I'll make the take-home thoughts presentation, which may be for about 5 minutes. That might answer some of the questions in the panel as well. Then we'll go for, remaining questions in the panel and then open house. Dr. Annie, please go ahead.
Yes. So we admitted her at 36 weeks of gestation age as it was planned. Her hemoglobin was 8.9. And luckily we repeated it and it was 9.2. And so we deferred a blood transfusion. Her admission INR was 2.5. Her echo serial reassessment, the gradients were normal. And here came the problem. The obstetric evaluation revealed that her per abdomen corresponded to 33 weeks. So what we did was the delivery plan was postponed to 1 week, and we continued her on VKAs. And we also did a periodic USG to assess the fetal weight. And we found that the baby was progressing into fetal growth retardation. So we planned to terminate at 37 weeks. So we switched out to heparin, 800 units infusion, and with APDT monitoring, we have to increase to 1,000. On day 3 of heparin, we switched over the heparin switch. Labor plan was formulated. Heparin was stopped 6 hours before labor, and cesarean delivery was done under general anesthesia. So restarted the heparin infusion. We overlapped it with warfarin, and we stabilized the INR. So as with the antenatal period, we had some difficulties in reaching the target INR, and she delivered a live baby, and the at-risk mother and the fetus are both, the newborn, both are fine. And one big challenge that we faced was the patient was too believe that she had to abort the baby. So we had to face that issue also, apart from the management. So, but by God's grace, she delivered a healthy baby. So that brings to the end of her story. So as Sir told, we'll now progress into the take-home points. I'll stop share here.
So thank you, Dr. Aneen. Thankfully, this went very well. Can you see the slides?
Yes, sir.
Okay, right. So the take-home point, the first thought I will share is that these patients have to be managed with the multidisciplinary team approach. And it is mandatory to provide the best possible care. You may not have all the experts that you see in the panel, but however, a cardiologist, an obstetrician, an anaesthetist, and preferably a pediatrician or a neonatologist are mandatory. Why do we need that? Because prosthetic valve during pregnancy is one of the largest cause of complications during pregnancy in women with heart disease. Number 2 is most of the complications are preventable. Number 3, evidence of the best care does not exist in certain crucial areas. Number 4, even the existing best care pathways are not known to everyone involved in the care. So it is very, very important that we develop this field, we develop this team in every institution which practices high-risk cardiac patients. Coming to preconception counseling, Dr. Karthikeyan clearly said mechanical prosthetic heart valve is only MWH class 3. This is not a contraindication for pregnancy. So during preconception counseling, we should reinforce the teaching about INR, what is INR, and the need to maintain optimal and consistent INR, and educate the patient about the anticoagulant management options available, switching options available, and what are the benefits, pros and cons, and encourage the patient to continue VKA as much as possible. However, the patient is very keen on switching, explain everything and help them to do the switching. This has to be done in the preconception counseling itself. And coming to the switchover, as we said, the first point of contact is often the cardiac surgeon or obstetrician or the cardiologist. So it's very important that we, do capacity building of the team to ensure that all of us are aware of the protocol. Every institution has to have a written down plan. It may not be evidence based, but it can be because we don't have evidence as of now. But as whatever evidence is available, whatever expertise is available locally, whatever facility is available locally, the entire whole hospital, the team has to follow a uniform protocol that will be very, very helpful. And switching is the time when most of the prosthetic valve thrombosis occurs. So hence, capacity building is extremely important in terms of how to do the switching. And Dr. Karthikeyan clearly highlighted safest regimen is vitamin K antagonist throughout the pregnancy. Not risk of warfarin embryopathy. The risk of fetal complications is less than 2%, and risk of warfarin embryopathy is very, very low. When the pregnancy requirement of warfarin is more than 5 and acetylene requirement is more than 2, the option of switching may be given. However, the mother may be allowed and encouraged to continue oral anticoagulation throughout pregnancy. And VKA dose should be monitored with PT-INR once in 2 to 4 weeks as per the need. Low molecular heparin must not be used without proper anti-10A monitoring to optimize the dose. Centers where both peak and trough levels of anti-10A levels are being monitored have shown good outcomes. Unfractionated heparin, the ideal dose, the ideal route is not very clear, but definitely not subcutaneous. Intravenous route is infusion or bolus. Subcutaneous, the absorption is a little bit more erratic than the rest of the dosage. About the antenatal follow-up, patients without complications should be followed up with the echo periodically and those with the complications more frequently, particularly when they are in the hospital, not otherwise. During the VKA, INR should be monitored once in 2 weeks, and then, if necessary, in 4 weeks. And I think monitoring on low molecular heparin, Dr. Geeta had mentioned very clearly. We'll be adding all that in our newsletter, including Dr. Pooja's and Dr. Geeta's input. Some of the red flags in PVT in pregnancy: decline in NYHA class, reduced perception of the prosthetic valve sounds by the patient, muffled heart sounds or clicks ausculted by the doctor, and tachycardia. These are some things that we should draw our attention. And prosthetic valve thrombosis in non-critically ill patients, maybe optimizing anticoagulation, but in sick patients, thrombolytic therapy is the first choice. Surgery is reserved for patients only with the failed thrombolytic therapy. Planned delivery has always better outcomes, and please, it is always good to have a written down delivery plan by 20 weeks of gestation age. Vaginal delivery requires a prior switch to IV heparin. Use of epidural anesthesia requires a longer interruption of anticoagulation therapy. So, limiting its use in patients with a high risk of prosthetic valve thrombosis. The cesarean section is an alternative, especially in those with high risk of valve thrombosis, so that to keep the time without VKAs as short as possible. Cesarean should be also performed in patients who are on VKAs where the labor onset occurs. Contraception recommended or LARC and sterilization, but not combined contraceptive pills. And thank you very much for your patient listen.